In the next 10 minutes, I will hopefully convince you that there is in fact a role for currently available biomarkers and genomics in the risk stratification of prostate cancer. I need to disclose that I have been an investigator for Genomic Health. I have no financial relationship with this company. So risk stratification, why does it matter? First and foremost, it equips us to make the determination if the patient is right for active surveillance versus treatment. There's other things that it can help us with, determining whether or not a node dissection is indicated, how much of a node dissection, whether or not to use neoadjuvant hormone therapy before radiotherapy, or adjuvant radiation therapy after surgery. So what do we have without biomarkers and or genomics? We have the PSA, the exam, the Gleason score, percent positive cores, and you can fold these into a variety of different nomograms to determine what an individual's risk stratification is going to be. These nomograms include NCCN model, AUA model, CAPRA, MSK nomogram, and others. If you look at the most recent edition of the NCCN guidelines, you can see that for low and for favorable intermediate risk disease, molecular testing of the tumor should be considered or can be considered if life expectancy is greater than or equal to 10 years. So what are your choices for biomarkers in this space? The NCCN lists 4: Oncotype DX, Prolaris, Decipher, and Promark. Starting with the Oncotype DX, this is a test that looks at a 17-gene genomic prostate score, or GPS, includes genes that are associated with worse outcome, genes that are associated with better outcome, and some housekeeping genes. These genes are used to calculate a GPS score, which is scaled 0 to 100, with 100 being worst case scenario. We looked at the association of GPS with tumor aggressiveness in the Center for Prostate Disease Research cohort, which is a DoD-wide prospective cohort with biologics, as measured by biochemical recurrence after radical prostatectomy and adverse pathology at surgery, which included both high-grade disease and or non-organ confined disease. This included 400 men, roughly, treated over about a 20-year period. 254 of these men were from Madigan, 148 were from Walter Reed. And what we found was that across NCCN risk groups, that there was a significant distribution of GPS scores within each of these separate subgroups. When you look at the receiver operator characteristics for biochemical recurrence and adverse pathology with and without GPS results with NCCN risk group, you can see a significant and statistically significant improvement in the area under the curve when you add in the GPS score. We then completed a meta-analysis with a cohort from UCSF to look at whether or not GPS would add predictive value to AUA risk group, NCCN risk group, and CAPRA score. This included 732 patients in the meta-analysis. And what we found here was that there were statistically significant improvements in the area under the curve for the receiver operating characteristics for adverse pathology in the AUA model and the NCCN model and the CAPRA model. There have been a couple of different clinical utility studies that have been published on the Oncotype DX test. One of these was published by Badani and included patients with NCCN very low to low intermediate risk prostate cancer with greater than a 10-year life expectancy. Urologists in this study indicated treatment recommendations pre- and post-assay questionnaires. The GPS results affected risk stratification both with shifts towards more aggressive disease and shifts towards less aggressive disease. But the net change was a 24% relative increase in the recommendation for active surveillance once the GPS scores were folded into the risk stratification. The next clinical utility study was published by Mark Dallera, and this was a retrospective study done in community-based practices, and it included two groups. First was the baseline group, which was treated prior to Oncotype DX becoming available. The second was the GPS group, which was obviously treated after it became available. In this study, you could see that there was a significant increase in the number of patients receiving active surveillance and watchful waiting across all three of the NCCN risk groups. The Prolaris test measures cellular proliferation, specifically 31 genes across multiple cell cycle progression pathways are looked at, along with some housekeeping genes. There's been a variety of published validation cohorts, including endpoints for 10-year mortality, biochemical relapses, and metastatic disease, and Prolaris has been predictive of each of these endpoints. In multiple variable analysis, it's clearly seen that the CCP score from Prolaris is independently predictive of prostate cancer death and biochemical relapse. In similar clinical utility studies, we see that with Prolaris, there's a change in management in up to 65% of patients. Also, similar to Oncotype, it extends the active surveillance candidate population by a significant percentage. The Decipher also exists in this space. This test includes 22 biomarkers across 5 different pathways. And you can see here that the Decipher test also independently outperforms other clinical risk factors. When you add in the Decipher results to NCCN, you have a statistically significant improvement in the area under the curve for metastatic risk. 3 of these tests are currently covered under LCDs, and the Decipher has a draft LCD for its biopsy test. Here's a back-of-the-napkin business case analysis that I performed on the airplane on the way here. If you had 100 low-risk patients that presented to your clinic, and you had a percent crossover to active surveillance that was consistent with what was seen in the Dallera study, assuming the cost of active surveillance is approximately $4,000 with 10 years, radical prostatectomy, approximately $10,000, radiotherapy, approximately $40,000. These are based on a JCO article. You would end up with a total cost for these 100 patients to be about $1.7 million. If you add in the GPS and have the anticipated shifts and add in the cost of the test for all 100 patients, the cost would be approximately $1.6 million. This saves approximately $100,000 per 100 patients, or about $1,000 per patient. This assumes a 50-50 split for patients receiving IMRT or radical prostatectomy for those not undergoing active surveillance. So if you draw an analogy to selecting the right treatment in low-risk disease to hitting the bullseye on a dartboard, I would ask, why would you want to be blindfolded? I'm not saying we should send it for every patient, but when you have the individual with low risk or favorable intermediate risk disease that cannot decide between active surveillance and treatment, this is the tiebreaker. So in summary, these markers are well validated for prostate cancer risk stratification. They yield actionable results. They're not cheap, but they're covered, and they yield a significant return on investment. We live in an era of precision medicine. This helps us get us there, and it's not for every case, but when you're on the fence, they can help. Thank you.